Hello everyone, and good morning, good afternoon, or good evening, wherever you are joining us from in the world. Welcome to the second in our Global Antimicrobial Resistance webinar series. My name is Professor Angharad Davis. I'm a consultant medical microbiologist by background and clinical director for publishing and engagement for the Royal College of Pathologists. I have also worked closely with the international team as a college vice president in the past, and I have the great privilege of chairing and moderating this webinar series. As I mentioned last week, almost a quarter of our members at the Royal College of Pathologists are actually based outside of the UK. And the purpose of this series is to bring together our international members and colleagues across the world to facilitate discussion and exchange of ideas and information between us about our different countries' situations and approaches with regards to the antimicrobial resistance crisis. So we've tried to include speakers from as wide a range of countries as possible. And the Q&A is a very important feature of these webinars. We hope that you will pose our speakers lots of questions, and we've allowed plenty of time for that. Before we get into today's presentations, I just want to give you a quick overview of the series. Our six-part series started last week, and we're delivering a webinar every week until the 12th of July. And each webinar starts with a UK speaker providing an introduction to the topic and the UK perspective, and then we will hear from speakers from countries around the world. The next webinar will be next week on the 19th of June, which is next Wednesday. Next week we'll be looking at antimicrobial stewardship in secondary care, hearing from countries Cuba, India, Nigeria and Qatar. On the 28th of June, there'll be a webinar on engaging the public in antimicrobial stewardship with speakers from Egypt and the United Arab Emirates. We'll then go on to explore developing prescribing guidelines on the 3rd of July, hearing from Egypt and India. And on Friday, the 12th of July, at a slightly later time of day, we'll be looking at evaluating an antimicrobial resistance programme, measures of success, hearing perspectives from Canada, Egypt and Hong Kong. This slide shows you the link to the college conference webpage where these webinars are advertised. That's where you'll be able to find them. Please bear in mind that if you wish to join each webinar, you need to join them all individually via these web pages. So this is the agenda for today's webinar. We will have the topic introduction and UK perspective from Meryl Davis, who I'll introduce in a minute, followed by the Nigerian and Sri Lanka perspectives from our other expert speakers, who I will also introduce before they speak. And afterwards, we'll have our Q&A session. If you have any questions throughout the presentations, please do put them in the Q&A box and we will aim to answer them later on in the session. We're going to take all the Q&As at the end, so we won't take Q&As in between speakers. We'll collect them all together and address them all with the whole panel at the end of the speaker presentations. So, to provide our topic introduction and UK perspective is Meryl Davis. I'm delighted to welcome Meryl to join us today. We're very, very pleased that she's been able to speak today. She's currently the lead antimicrobial pharmacist for primary and community care for Public Health Wales. She also holds an independent prescriber qualification and is extremely experienced in this topic area. So thank you very much for joining us, Meryl, and we look forward to hearing your presentation. Thank you.
Fabulous. So thank you very much to Angharad for the kind words of introduction, and also to the Royal College of Pathologists for inviting me to speak with you here today. UK perspective from the perspective of antimicrobial stewardship in primary care, with a bit of a Welsh slant, because obviously healthcare in Wales is devolved. So this is what the structure of primary care in Wales looks like. So from that perspective, it's controlled by Welsh Government. where we have 7 local health boards, and the 7 local health boards then encompass secondary care, primary care and community services. And within the community services, we have more than 700 community pharmacies, as well as our dental and ophthalmology contractors. And within primary care, we have GP out-of-hours services and 60 clusters. And within those clusters, we have more than around 374 GP practices. And within the GP practices, we have a whole host of healthcare professionals working, from general practitioners to pharmacists, practice nurses and healthcare support workers, and other allied healthcare professionals such as physiotherapists, podiatrists, and paramedics. So as mentioned earlier, the primary care in Wales is split from the perspective of health boards, and there's 7 health boards as mentioned earlier. And this is just a graph, a map, showing Wales and the different health boards. And some of them look very much bigger than the others. But if we take an example here of health board number 6, which is Powys, it's a very large health board geographically, but has a small population because of its rural nature. Whereas Cardiff and Vale number 3 is a small geographical area, but has a high population due to its urban nature. And as mentioned earlier, within Wales, the health boards break their health boards down into smaller areas known as clusters. And a cluster brings together all the local services involved in health and care across a geographical area that typically serves around 25,000 to 100,000 people. And the aim is that working as a cluster ensures that care is better coordinated for the patient and the well-being of the individuals living within that community. So an example here is for Swansea Bay University Health Board that has 8 clusters of varying geographical nature and population size. So antibiotics prescribing in primary care in the United Kingdom, around 80%, so the vast majority of the prescribing of antibiotics in the UK is done in primary care. And around 70% of these prescriptions originate from general practice. So the vast majority of our prescriptions come from general practice. In Wales, over 2 million antibiotics are dispensed by community pharmacies every year in Wales. And evidence suggests that in the United Kingdom, at least 20% of these antibiotics aren't clinically needed. So they're prescribed for conditions that are generally self-limiting in nature or may even be viral in nature. So how do people access antibiotics in primary care in Wales? And this is very similar for the United Kingdom as well. So the vast majority of medicines are supplied via our community pharmacies. And within the United Kingdom, we have systems in place that if there are stock issues identified, alternative options are usually communicated. And this is normally via a protocol called a serious shortage protocol. So if there's a problem with a certain antibiotic, a serious shortage protocol is issued, and that allows the community pharmacist to switch that antibiotic to another antibiotic that's recommended within that protocol if there's a shortage of that specific antibiotic. Prescribing of antibiotics within the United Kingdom are prescription only. The vast majority, as mentioned, are written by general practitioners, but also dentists and midwives can prescribe antibiotics, as well as other independent prescribers, such as nurses, pharmacists, physiotherapists, podiatrists, and optometrists. Prescriptions are free of charge in Wales and Scotland and in Northern Ireland, but actually in England, there is a prescription charge for antibiotics. People can also access antibiotics via patient group direction within the United Kingdom as well. And these are written instructions that allow authorised healthcare professionals to sell, supply, or administer a named medicine in an individual clinical situation legally without needing a written patient-specific prescription from an approved prescriber. An example of this is the Common Ailment Service that is provided via community pharmacy within Wales that enables the management of 26 minor conditions. And the table that you see here gives examples of some of the conditions treated by the Common Ailment Services. So things like oral candidiasis, athlete's foot, scabies, ringworm, and other infections are included within that services. And within that service, people are able to access treatment free of charge. Scotland and England have very similar services as well, called Pharmacy First. So from the perspective of the United Kingdom, there are antimicrobial stewardship groups. And within Wales, we have the primary care work stream of the Antimicrobial Resistance Delivery Board and its associated working groups. And just this group allows the opportunity to bring all healthcare professionals working within primary care together to learn about good practice around antimicrobial stewardship within primary care, identify areas of concern or that need intervention, and to allow us to develop interventions or guidance to help with antimicrobial stewardship within primary care. Within Wales, we have the All Wales Primary Care Antimicrobial Pharmacist Group as well, and this brings the network of all the antimicrobial pharmacists that work within primary care in Wales together, and again, gives us the opportunity to share good practice, learn about various interventions, allow people to shared audits and other guidance that they've developed so that we're not reinventing the wheel across Wales, and also to enable us to develop national guidance as well. All the health boards within Wales have antimicrobial stewardship groups as well, which have primary care representations, and some health boards even have subgroups or working groups focused on primary care antimicrobial stewardship. So within the UK, we have the UK National Action Plan. Quite a few years ago now, back in 2013, a report was published called Tackling Drug-Resistant Infections Globally. And from that, the UK developed a 5-year antimicrobial resistance strategy that ran from 2013 to 2018. And then in 2019, a new 20-year vision for antimicrobial resistance for the UK was published called Contained and Controlled. And within that 20-year vision, there are going to be 4 iterations of 5-year national action plans. And the most recent national action plan, Confronting Antimicrobial Resistance, which runs from 24 to 29, was published this May. Within that national action plan, we have specific targets from the perspective of prescribing of antibiotics. So by 2029, the UK aims to reduce total antibiotic use in human populations by 5% from the 2019 baseline. And also by 2029, the UK aims to achieve 70% of total use of antibiotics from the access category, which is the new UK category, across the human healthcare system. And within Wales, we have the Welsh Health Circulars, which are very much aligned to the new UK National Action Plan, but also provide specific interventions for primary care within Wales from the perspective of antimicrobial stewardship. Within Wales and other countries as well have various different indicators specific for primary care. So in Wales, we have 2 specific national prescribing indicators, one looking at total antibacterial items per 1,000 star PUs, and the other one looking at the 4 Cs antimicrobials. So these are the broader spectrum agents of coamoxiclav, cephalosporins, fluoroquinolones, and clindamycin, and looking at the denominator of items per 1,000 patients. And these provide either health board targets or GP targets from the perspective of reduction of prescribing. So when we look at antibacterial items per 1,000 star PUs for Wales, we can look at the health boards plotted against each other, and we can then look at the percentage change in prescribing compared to the target year. So we can see that some health boards are doing reductions from the perspective of the prescribing, whereas others have not been quite as successful from the perspective of reducing their prescribing. We can also see as well from the graph that in December 2022 quarter and the first quarter of 2023, we had quite a big increase in our prescribing. And this was due to a Streptococcus A outbreak that we had in the United Kingdom. Then from the perspective of 4C antibacterial items, again, from this national prescribing indicator, we can see that all the health boards have been making reductions in the prescribing of these broad spectrum agents, but some health boards have been seeing a greater reduction compared to others. Within the United Kingdom, the services within primary care are contracted to GP practice, to dental contractors, community pharmacy contractors, etc. So within that, within those services, we try to have interventions from the perspective of antimicrobial stewardship. So an example within Wales is that the National prescribing indicators are currently included in the GP contract, and we've previously had UTI audits included in the quality assurance and improvement framework included within the contract as well. And within that, we had 4 specific UTI audits. An example from England is that there are several interventions from the perspective of antimicrobial stewardship included in the community pharmacy contract. Health boards, as well as the clusters, have local incentive schemes, and these are targeted towards the priority issues within that each individual health board. And these need to be completed by the individual GP practice to ensure that the GP practice receives payment. Examples of these projects could be a sore throat audit or a 4C audit. So they could be looking at some specific problem area for them. So if they're high prescribers of coamoxiclav or cephalosporins, they could complete an audit on those specific groups of drugs. And another example could be a UTI quality improvement project. So looking specifically at UTI management, and it could be even targeted toward a specific group such as the over 65s. And then the feedback then is provided to the GPs and learning points communicated so that hopefully that continuous learning happens and that there's a continuous improvement in antimicrobial stewardship and prescribing of antibiotics in primary care. Within the United Kingdom, there's a lot of data from the perspective of antibiotic surveillance, and I've given some examples here of how we access that data. So from the perspective of the United Kingdom, we can access prescribing data on casper.net as well as Prescrip. And then in the United Kingdom, and within Wales, we access our national prescribing indicator data on Spira, and then we access Wales-specific data on Llygad, which is the antibiotic data library for Wales, which provides data for both prescribing in primary care and secondary care, as well as antimicrobial resistance data. And the antimicrobial resistance data within primary care in Wales goes down to health board and cluster level. So the common infections in primary care in Wales and similarly across the UK is that respiratory infections tend to be the most common infection, then urinary infections, skin infections, gastrointestinal infections, and then genitourinary medicine. We develop guidelines across the United Kingdom. We have UK guidance from the perspective of NICE, and then there's various country-specific guidance. So you have guidance from SIGN for Scotland, and then from the perspective of Wales, we have specific guidance for primary care antimicrobial guidelines, management of recurrent UTI in adult women, and for the management of Clostridioides difficile infection. And guidelines within the United Kingdom are developed as empirical guidance, which are indication specific, which includes dosing information and duration of treatment. It's written based on the best available data, looking at the organism likely to be causing the infection, looking at local resistance data, the evidence base for that infection, and thinking about the antibiotic site of infection and tissue penetration, and trying to use narrow versus broad spectrum agent where possible. We have access to cultural sensitivities in the United Kingdom. Prescribers are directed to take samples in certain instances, for example, urine or blood cultures, and results are returned on an online system. Sensitivities are released, but within Wales, broad spectrum options are suppressed where possible. And within Wales, we have national and tailored messages appearing on the results to help guide the prescriber on what they should be using for that specific infections. And the results are usually received within 48 hours and are freely available. We have audit and quality improvements resources available to our prescribers. I've got the Welsh example here from the perspective of the CEP national audit for focus on antibiotic prescribing, and these could be for a drug class or for a specific indication. So an example here is the audit for antibiotic prescribing for acute sore throat. Within the United Kingdom, there are other audit packs available, such as those available on the Target package. To optimise antibiotic prescribing in primary care, we should be reserving the use of antibiotics for bacterial infections where there is a clear benefit of treatment using antibiotics. We shouldn't be prescribing antibiotics for infections that are viral in nature or self-limiting in nature, where there is only a marginal benefit from antibiotic treatment. And one of the strategies that helps us from the perspective of promoting antimicrobial stewardship in primary care and the management of self-limiting conditions is the use of backup antimicrobial prescribing. So examples of self-limiting infections are things like acute otitis media and acute sore throat and acute cough. We know that, for example, for acute sore throat, the vast majority are viral in nature, around 80%. Sore throats usually last for around 3 to 7 days. And by 7 days, most patients are symptom-free, whether or not they've had an antibiotic or not. And taking an antibiotic only reduces pain by around 16 hours. So for these self-limiting infections, what we would prefer to use is a backup antibiotic strategy. And NICE recommends that prescribers in primary care can use a backup antimicrobial prescription when there is clinical uncertainty about whether a condition is self-limiting or is likely to deteriorate. And the rationale for using a backup prescribing strategy is that it encourages self-management as the first step and allows the person to access antimicrobials without having the hassle of having another appointment if their condition worsens. The backup prescription can be given to the patient with appropriate instructions to not access that prescription unless they don't get better or their symptoms worsen, or it can be held in the surgery, for example, in the reception, or another location such as the community pharmacy if the patient needs to pick up that prescription. And when we utilize a backup antibiotic strategy, we have to remember the 6 R's. So to reassure the patient that an antibiotic isn't needed now and the reasons why not to use the antibiotic. So things like side effects, allergies, and antimicrobial resistance. Provide advice on symptomatic relief and self-care. Give information on the realistic natural history of that condition. So for example, a cough can last up to 3 weeks. To reinforce key messages, so only to use the antibiotics if they get worse or they don't, or the symptoms don't start to settle within an agreed time frame, and provide rescue information as well, so safety netting information of when they need to seek further help. We also use a diagnostic algorithms in the United Kingdom to try and stratify which patients are more likely to have a bacterial infection and which are more likely to have a viral infection and don't need antibiotics. So examples here are the fever pain and the Centaur score that we use for sore throats, the Curb 65 score that's used for community-acquired pneumonia, and a UTI diagnostic algorithm. We also use point-of-care testing in the United Kingdom and Wales. So an example would be the sore throat test and treat service that we have in Wales, where a sore throat swab is completed for certain patients with certain Centaur or fever pain scores. And then that point-of-care test then will tell the community pharmacist whether that patient has a bacterial or a viral infection. And if they have a bacterial infection, then they're able to have antibiotics using a patient group direction. Another point-of-care test would be a CRP test that is used for respiratory tract infections in Wales that again would allow us to stratify which patients are more likely to have a bacterial infection and would benefit from an antibiotic prescription. We have a lot of stewardship material and resources available within the United Kingdom. And one of the resources available is the Target resource, which is a resource developed via the UK Healthcare, UK HSA and the Royal College of GPs. And we in Public Health Wales also work with the Target team within UK HSA on those resources as well. And within those resources, there are examples from the perspective of leaflets for patients, training resources, self-assessment checklists, and other audits and toolkits. And within Wales, we also have resources and materials on the Public Health Wales website as well. Included within those resources are things like waiting room posters to try and promote antimicrobial stewardship when people are visiting their GP practice or the community pharmacies. So examples here are how people can manage their common infection and a poster on antibiotic resistance. And also we have a lot of leaflets developed from the perspective of antimicrobial stewardship that we share with patients that help them to self-manage their infection, understand their infection, and also to try and prevent further infections as well. So examples here are the how can I manage my common infection for adults, the UTI infection leaflet, and the when should I worry leaflet, which is specific for children. There's a lot of work from the perspective of prevention of infection in the United Kingdom. So we have a national childhood vaccination scheme, as well as an adult immunization scheme, as well as a scheme for travel vaccinations. There's a lot of promotion of self-care from the perspective of hand hygiene, cough etiquette, hydration, skin integrity, and also self-management of their infection. And also other healthy lifestyle interventions. So from the perspective, an example here would be smoking cessation or obesity management. So a lot of interventions that we try to complete to prevent infections so that we don't have to use antibiotics in the future. We'd also do a lot of local and national education and have close link with educational providers, including universities and Health Education and Improvement Wales. The health boards also provide specific sessions to GPs and allied healthcare professionals and community pharmacists. And these teaching sessions could include things like guideline updates, specific infections such as respiratory or urinary tract infections, or any other clinical alert and updates. So thank you very much for listening. And that's just a quick whistle-stop tour of the stewardship interventions in the United Kingdom with a slant of the Welsh perspective from here in Wales.
Thank you very much, Meryl, for that really comprehensive introduction to the topic. And you covered so much ground there. I'm sure there'll be lots of questions about some of that content, but really, really interesting and comprehensive. Thank you very much. I'm just going to reshare my own screen now, because we're now going to move on to introduce our next speaker, who is going to talk about the Nigerian perspective, and that is Professor Samuel Taiwo. I'm delighted that Professor Taiwo is able to join us. Thank you very much for finding time to speak at this webinar today. Samuel Taiwo is a professor of medical microbiology and a consultant clinical microbiologist at the Ladoke Akintola University of Technology and Teaching Hospital in Nigeria. He's the chair of his hospital's clinical microbiology laboratory, infection prevention and control, and antimicrobial stewardship committees, and a member of the National Antimicrobial Stewardship Working Group of the Clinical Microbiology and Infectious Diseases Society of Nigeria, that produced a manual for antimicrobial stewardship programs in Nigerian healthcare facilities in November 2023. So he has much expert knowledge to share, and I'm delighted that he's able to join us. Thank you very much, Professor Taiwo.
Thank you, Professor Davis, for that introduction, and thank you to the Royal College of Pathologists for giving me this opportunity to talk about the Nigeria perspective on antimicrobial stewardship in the community. And I'll follow this outline. Yeah, as a background, Nigeria is the most populous Black nation and the 6th most populous nation in the world, with a projected 230 million people in year 2024. Nigeria runs a 3-tier system of government. You have the federal government, state government, we have 36 states, and then you have a local government, 774 local governments at the present moment. Nigeria also has 6 distinct geopolitical regions, 3 in the north, 3 in the south. This population is served by a healthcare system that is organized into 3 levels. You have the primary care, which basically serves the community, and it forms about 88% of care delivery service in Nigeria. It's both public and private. And you have the secondary care, that forms about 11.6%. It's mainly public under the management of the state government. And then you have the tertiary care that subserve about 0.25% of the healthcare service delivery, which is both public by the federal government and state government, also private, as well as faith-based tertiary healthcare service delivery. Now, the public primary healthcare service, which I said basically subserve community, is under the control and legal framework of the National Primary Healthcare Development Agency. Now, this agency sets the minimum standard for primary healthcare in Nigeria. The healthcare facilities under this primary care is also organized into 3 levels. And based on the current nomenclature, you have the primary health center that is under the management of the local government. And you have one primary health center in a ward. You have about 10 wards in the local government. Then you have the primary health clinics, which is also under the management of the local government and ward development committee. And then you have the health post, which is the smallest of that unit, that is managed by the village committee or the community development committee, and subserve each health post to provide healthcare service to about 500 patients. Now, the private public primary healthcare service is not under the legal framework of the primary healthcare at the National Primary Healthcare Development Agency. It includes hospitals and clinics that are run by general practitioners and some by non-governmental organizations, and also healthcare service rendered by community pharmacies, patent and proprietary medicine vendors, many of whom are not registered or licensed. Those who are traditional medical practitioners, nursing homes, and sometimes you have stand-alone medical laboratories, all these working at the community level. Now, looking at the public primary health care in terms of structure and personnel who are targets of antimicrobial stewardship, they are key stakeholders as far as antimicrobial stewardship is concerned. At the primary health center, usually under the supervision of the medical officer of health. Now, this medical officer supervises group of health centers, who each of these health centers are supposed to be headed by a nurse or midwife and supported by other health personnel like community health officers, community health extension workers, pharmacy technicians, laboratory technicians. And at this level, there is complete essential drug list that is to be utilized at this level, guided by the national standard treatment guidance. Now, in many situations, you don't have nurse to head this health center, so you have community health officers heading this primary health center. Now, these community health officers are, first of all, community health extension workers who have had a 3-year training at the School of Health Technology, and they have been certified with a diploma in community health care. And so they can head this primary health care, but they must work with standing order for community health officers. By the guideline, they are supposed to spend 30% of their time at the community and 70% of their time at the primary health center. The primary health clinic are also supposed to be headed by a nurse or midwife, but in most settings, you don't have a nurse heading this. You have community health extension workers and then supported by other workers. Now, these are described as the first-line antibiotic prescribers and dispensers in Nigeria, because it is at this level that the guideline, the minimum guideline, empowers them to prescribe and to dispense antimicrobials, drugs including antimicrobials. And they have received some minimal training on antimicrobial use and prescribing for common clinical conditions. But they have to work with current standing order for community health workers. And they are also supposed to spend 50% of their time in the community and 50% of their time in the health clinics by the minimum standard. The health post is the smallest of them, usually headed by junior community health office, workers, supported by community resource persons like volunteer health workers and traditional birth attendants, who are trained ad hoc staff that support the junior CHU. And they're supposed to spend 90% of their time in the community and 10% of their time at health post. But they must work with standing order for junior community health workers. However, the minimum standard does not enable them to prescribe anti-infective drugs. This is a result of a national survey that was conducted in 2020 on antimicrobial awareness and prescribing behavior of healthcare workers across the 3 levels of care delivery service and across the 6 geopolitical zone, which was conducted by multi-stage and systematic random sample in 2020. And the finding of this study shows that healthcare personnel at the primary healthcare level had significantly lower knowledge score of AMR and AMS when you compare them to those from the secondary and tertiary healthcare facility. And when you look at the community health workers in terms of profession, the community health workers are the ones that are basically at the primary healthcare level. They also had significantly lower knowledge score as far as AMR and AMS is concerned. And that negatively affected their prescribing behavior when you compare that to physicians, nurses, or dentists, and others. So this study shows significant gap in knowledge of AMR and AMS among healthcare personnel at the primary healthcare level that serves majorly the community. Now, looking precisely at antimicrobial prescribing behavior of healthcare workers at the community level, there are 2 studies that I'm presenting here, one from the north, one from the south. One from the north was conducted in 2020 on antimicrobial prescribing at the primary healthcare workers, who are all basically community health extension workers in the 3 geopolitical regions in the north central, northeast, and northwest. The one in the south was also looking at antimicrobial prescribing behavior from the outpatient setting of 6 primary healthcare centers in Lagos, Southwest Nigeria, using the Global Point Prevalence Survey of Antimicrobial Consumption and Resistance, Global PPS. This was done in 2023. And the result of these 2 studies are very comparable. There was high antimicrobial prescribing rate at the time of the survey, 75% in the north, in the south, and 98%. There were poor prescribing practices with misuse and abuse of antimicrobials, essentially because there were no access or lack of access or lack of awareness of the standard treatment guideline or the national standing order. And in situations where they had this standing order in the north particularly, there was poor adherence or even non-adherence to the standing orders, due to several reasons, various reasons adduced by these workers. There were no laboratory support across these facilities. In Lagos, where there was use of rapid diagnostic tests and sepsis biomarkers, their use was very low and inappropriate in this situation. And of course, there was absent formal antimicrobial stewardship program across all the facilities that were surveyed here. Now, looking at antimicrobial stewardship implementation at national level, the national effort of the Nigeria Center for Disease Control and Prevention, the National Action Plan 1.0, which was between 2017 and 2022, when you look at the implementation rate across the 5 strategic areas, it was 44% across board. But looking at the antimicrobial stewardship strategies, it was less than 30% in terms of the implementation. And most of the hospitals that were supported by the national effort, as shown on the map here, were basically, tertiary and probably secondary care facilities. There was probably no facility from the community that was supported with this national effort. Looking further at antimicrobial stewardship implementation at societal level, the most active society as far as antimicrobial stewardship implementation or drive is concerned is the Clinical Microbiology and Infectious Disease Society of Nigeria, the CLIMIDSI. In 2018, this society established the National Antimicrobial Stewardship Working Group, NASWORK, for the society, and it charged them with the responsibility of producing locally derived evidence-based guideline that will assist healthcare facility across all levels to be able to start antimicrobial stewardship program, implement the activities, and sustain and maintain stewardship programs in their facilities. So after 5 years of doing a lot of work, gap and challenges analysis, and having received some support from BioMeru, this group was able to develop the medicine manual for antimicrobial stewardship programs in Nigerian healthcare facilities. And this manual was launched during the last conference of the medicine in 2023, November. And although the hard copy is yet to be produced, it is been published in the African Journal of Clinical and Experimental Microbiology. The link is there. So this manual going forward will be very useful in helping setting up antimicrobial stewardship program by any healthcare facility across the level in the country. So what are the challenges of AMS practice in the community that we have noticed? Like I've presented, poor knowledge and awareness of AMR and AMS by key stakeholders at primary healthcare level. And this, I believe, must have been partly responsible because we are not involved in the National Action Point 1.0 strategies of the NC. This may partly contribute to their poor knowledge. There's also non-involvement of the private health sector, general practitioners, community pharmacists, and others in the legal framework of the primary healthcare center. This is going to be a big challenge because at what point do you bring these people into antimicrobial stewardship by the community level? There's also inadequate human resources, which has been made worse by mass immigration of healthcare workers from Nigeria, what we now popularly call the gap passing. This is very concerning. Of course, there's poor laboratory support across board in terms of capacity and in terms of standard quality. That impedes diagnostic stewardship, which is an important component of antimicrobial stewardship. So how do we mitigate these challenges and move forward as far as AMS is concerned in the community? At the National Primary Healthcare Development Agency, I think there is need for engagement of key stakeholders at this primary healthcare level, including the Director General of the agency on AMR awareness, education, and training. This is very important. And I think there should be a line budget that will support antimicrobial stewardship at the primary healthcare level. Last week or thereabout, the federal government of Nigeria announced that they have earmarked 260 billion naira to revitalize primary healthcare across the nation. I think this should be a big boost if AMS is also concerned, is also considered in this kind of funding at the primary healthcare level. The NCDC will have to engage better with the primary healthcare development and private health sector, and key associations like the Medicine, Nigeria Society for Pharmaceutical, Nigeria Pharmaceutical Society, Nigerian Infectious Disease Society, and many other societies that are key stakeholders in antimicrobial stewardship. And of course, we shouldn't leave the drug regulatory agencies, the NAFDAC, and the Pharmacy Council of Nigeria. Shouldn't leave them out. There should be continuous engagement with them. The National Action Plan 2.0, which is about to be released, I believe should include provision for AMS information and support to healthcare workers at the community level. And for clementing and nurse work, I think the clementing manual will be useful. So this should be made available to any healthcare facility across level, so I can assist them in starting AMS program and implementing the activities and monitoring and sustaining it. And of course, clementing and nurse work members will also be ready to engage the National Primary Healthcare Development Agency, the general practitioners, community pharmacists, and others, using different public engagement tools and processes that we have discussed in past workshops. This will help to drive AMS beyond tertiary and secondary care down to the community level, which constitutes the largest portion of healthcare delivery service, where probably antimicrobial prescribing is greatest. So that they are not left behind in this fight against AMR. So I want to thank the Royal College of Pathologists and all other persons acknowledge the support. Thank you very much for listening. Over.
Thank you very much, Professor Taiwo, for that great overview of antimicrobial stewardship in Nigeria, in the community. Really informative and interesting. Thank you very much. Again, I'm sure there'll be questions about that at the end. And if you do have questions, please do put them in the Q&A. We'll go through them after our final speaker has presented. So we are now going to go on to our final speaker of this session, who comes from Sri Lanka and who is Dr. Kushlani Jayatilake. And I'm delighted to welcome her and thank you very much for joining us today. Dr. Jayatilake is a medical microbiologist, consultant since 2004. She's also honorary senior lecturer working at her university and medical school. Now I'm just going to get the slides up. Here we are at Sri Jayawardenepura General Hospital and University in Sri Lanka. And Dr. Jayatilake is also a member of the Sri Lanka National Advisory Committee for Combating AMR. So thank you very much again for joining us, and over to you.
Thank you.
Can I share my slides?
Yeah.
Yes. Yeah, okay. Can you all see the slides?
Yes, we can. Thank you.
Okay. Good morning, good afternoon, and good evening. And thank you for inviting me to deliver this talk and for that introduction. So I'll be talking about the importance of the antimicrobial stewardship in the community in Sri Lanka and what has been done so far, and the strengths, weaknesses, opportunities, and threats we have, and the way forward. So Sri Lanka is an island of 65,000 square kilometers around and with a 22 million population in the Indian Ocean. And it's a low middle income country. If you look at this report of the Institute for Health Metrics and Evaluation, they have reported that in 2019, 2,300 deaths were attributed to AMR and 8,800 deaths associated with AMR from Sri Lanka. But I'm sure it's much more than that. And then they also report that Sri Lanka has the 58th highest age standardized mortality rate per 100,000 population associated with AMR across 204 countries. And if you look at the data that we have published in the Global Laboratory-Based Antimicrobial Resistance Surveillance System of the WHO, in 2020, the blood culture Klebsiella pneumonia isolates, if you look at it, the Sri Lankan data, 67% were resistant to third-generation cephalosporins. Whereas if you compare it with other countries, the Asian countries are also having resistance. But if you look at the European countries, the same resistance in the Sweden, 6.1, and the Switzerland and the United Kingdom, around 10%. So we are having a very big problem of antimicrobial resistance in our country. And this is a community-based prevalence study which was done in Colombo district, that is the district which we have the capital city, and 14% of our population is colonized with MRSA. And in 2014, we had a look at the urine isolates, coliforms from urine cultures from different hospitals, multi-center hospital. And we have analyzed the inpatient and the outpatient setting data separately. And we can see outpatient setting, the resistance was less, but still the cefotaxime resistance, third generation cephalosporin resistance was close to 40% even in outpatient setting. And first generation cephalosporin and amoxicillin clavulanic resistance was very high, more than 40%. And this is again an internationally published multi-center study where Sri Lanka data was published, and SOP data of Streptococcus pneumoniae in 2001, where we can see that Sri Lanka had 76% resistance to penicillin in Streptococcus pneumoniae, carriage isolates, and more than 40% resistance in the clinical isolates. So if you look at the healthcare system in Sri Lanka has healthcare system which comprises of different types of medicine, including the traditional Ayurveda and acupuncture and so on. But Western medicine is the leading sector catering for the majority. And it provides both public and private sector healthcare in the Western medicine field for inpatient as well as outpatients. And the public sector provides the bulk of inpatient care. In 2020, 5 million hospitalizations and over 38 million outpatient visits occurred in public sector. And the majority of services in the country, including inpatient care, like about 95% of the inpatient care and around 50% of the outpatient care is provided by the public sector. But the role of the private sector is now growing with the, but accessibility to the fraction of the population who can afford the high cost of it. So only the registered medical doctors of the Western medicine are allowed to prescribe antimicrobials by law. And this was a national consumption survey of antimicrobials carried out recently in Sri Lanka. According to this, actually 54% prescribed antimicrobials, so antibiotics were access group. And this shows still some of these antibiotics like quinolones, like ciprofloxacin, azithromycin, coamoxiclav, amoxicillin, high level of consumption in the private sector. But when you look at, and also you can appreciate that this oral cefixime, that is a third generation cephalosporin, again, high use is consumption seen in private sector. But if you look at how they have defined this private and public sector, it's like this. This is the supply chain in Sri Lanka. The State Pharmaceutical Corporation and the Medical Supplies Division supply the public sector hospitals, and private sector hospitals are supplied by private importers and manufacturers, local manufacturers, and there are community pharmacies who are mostly private, but apart from few state-run pharmacies. So now this public-private, though they have separated this way, some of these prescriptions from the public sector may go to the private pharmacies. Therefore, there may be a little bit of a over-exaggeration of the private consumption here. So what has been done so far? The Sri Lanka has published the National Strategic Plan for Combating Antimicrobial Resistance in Sri Lanka in 2017. And now we have revised it for another 5 years from 2023 with a costed operational plan. And there are some hospitals which antimicrobial stewardship programs are conducted at different levels. And aware classification of the WHO is now incorporated into a circular where it had been sent to hospitals with pre-authorization approval described for reserve antimicrobials. And national guidelines for empirical and prophylactic antimicrobial prescription is available in the web. And training of in-service training for the doctors, nurses, pharmacists are carried out regularly. And public awareness, especially during the World AMR Awareness Week, is carried out, though I have put 2 of my pictures. This is not only me. Everybody, lot of people will go on the national TV to talk about AMR, and people are being educated regularly. So our strengths are, we have a One Health National Advisory Committee and a National Action Plan Implementation Strengthening Team for antimicrobial resistance, with a very high level commitment from the Ministry of Health, where Director General of the Health Services and the Director General of Agriculture and Veterinary Services co-chair in the National Advisory Committee, and a national focal point being the Deputy Director General of Laboratory Services of the Ministry of Health. National Strategic Plan was published with a costed operational plan, and public and private sector healthcare has qualified medical practitioners, and strong ground level preventive healthcare system is in place, and with qualified doctors, with specialists, nurses, pharmacists, and MLTs are available. And private pharmacies by law should be run by a qualified pharmacist. And there is continuous medical education programs conducted by different professional colleges, such as the Sri Lanka Medical Association, Ceylon College of Physicians, Sri Lanka College of Microbiologists, and for the GPs as well. And the guidelines are available for empiric therapy, laboratory services available, though it may not be very cheap, so it's expensive. But high literacy rate in the community and high literacy in the females, I think, is a strong point. And availability of trained IT professionals, including doctors specialized in bioinformatics, is now available. And the weaknesses that we have are that antimicrobials are categorized as a single group in the national formulary, and this classification, though we have suggested, still not incorporated into it. And general medical practitioners, though qualified and registered, there's no proper monitoring system in the Ministry of Health with proper mandatory participation in the CME programs and so on. No regular auditing and feedback on community prescriptions. And the laboratory tests are too expensive for the general population, and no allocated budget for implementing the AMR activities in the country. And the opportunities are that we have the high-level commitment in the National Advisory Committee, and availability of funds through different funds like Fleming Fund, strong public and private health systems, including the preventive care, and the high mobile phone use may be useful, and internet facilities are available throughout the country, and the high literacy in the community. So threats are no legislation to implement the aware classification and the community antimicrobial stewardship, no design program to implement this AMR AMS in the stewardship, and monitoring of prescriptions is difficult because of this widespread private sector, which is not controlled very well. And reserve and watch antimicrobials are freely available in the community pharmacies, like oral linezolid and oral cefixime. and we don't have a regular supply of essential antimicrobials sometimes, like the oral penicillin may not be available at times, which may cause them to use more broader spectrum antibiotics. And diagnostic facilities are not optimal and may not be available or may be too expensive. So changing the practices also is difficult. So the way forward, I would suggest that we need to update our legislations and policies to include the aware classification and implementation of this antimicrobial stewardship in the community, and identify adequate budgeting for these implementation activities, and to have a method of monitoring and feedback of antimicrobial prescriptions in the community, and regular supply of medicines, and also the guidelines of stewardship, including the diagnostic stewardship, and to improve the diagnostic facilities in the community setting, maybe to subsidize testing facilities so that it will be available to everybody, and to have maybe a rewarding system for the good practices. Thank you.
Thank you very much for that really excellent presentation with so much information and insights into the situation in Sri Lanka. Thank you, that was great. Perhaps if you could stop sharing those slides now, and we'll be able to go on in a second to the Q&A. I can see several people have already put some questions into the Q&A. Before we engage the panel in that, I know that the college has a poll to run. I believe that Kelly is going to run a poll for us where you can all enter what country you're dialing in from, because that would be useful information for us. So I think that the international team is about to launch that poll. Here we are. If you could just type in the box the country that you are joining from, and then we will be able to capture that data for our records. I'll just give you a few seconds to do that, and thank you for helping us with this. So I'm going to carry on now with the Q&A. So if our panelists could appear in person again, that would be wonderful. I'm going to start with the questions that are already in the chat. The first one is, can you please explain the aware classification of antibiotics? Now, I can see that Professor Taiwo has already said that he would like to answer this question. So over to you.
Okay, thank you for the excellent question. Yeah, the aware classification of antimicrobials was done by WHO in 2019 to assist antimicrobial stewardship activities. And it categorized the antimicrobials into 3 groups: the access category, the watch categories, and the reserve category. The antibiotics in the access category, which according to WHO should be the main antibiotics that where most prescription to be done in healthcare facility. 60% of antimicrobial prescribed in a facility should be from the access group, because these are antibiotics that are available to treat common infectious conditions. Resistance is not a major problem. These categories of okay. Those in the watch categories are supposed to be antibiotics that are reserved for evidence-based infection. You have an evidence and then prescribe that. So they are, they're supposed to be prescribed based on evidence that there's an infection. Because resistant to these ones are going to be very problematic. And then those in the reserve are the antibiotic of last resort. And these are supposed to be under stewardship watch. They are prescribed for very serious life-threatening conditions. They are reserved for treating life-threatening conditions, and resistant to them we spare June because they are the last resort. If we misuse them, then you will not have any antimicrobials to treat multi-drug resistant infections, and that we spare. I think that's just what WHO categorizing these antibiotics.
Great, thank you very much. And Dr. Jayatilake, you also mentioned the aware classification. Was there anything that you wanted to add about it?
Yeah, so the WHO aware classification has only the antibiotics there still, so antibacterial agents, whereas in Sri Lanka now we have modified the list to include the other antimicrobials as well. And so we are now trying to implement it in a broader way with some restrictions for the reserve antibiotics, which are very important group of antibiotics, which are like, it's only for like necessary when the patient has an antibiotic resistant organism causing an infection. So therefore, there's no need for that to be started by any doctor in the community, I suppose, the reserve antibiotics. So this is what we have tried to, now we are trying to reserve that for only the necessary important infections where the antibiotic resistance has caused the infection. When we know that this is a antibiotic resistant organism which is causing, or at least when we know that it's likely to be an antibiotic resistant organism based on the patient's patient factors and the infection factors. So this is how we are trying to do in Sri Lanka by restricting the reserve antimicrobials prescriptions only to the really needed people by probably the approval of the microbiologist is needed for that.
So you've sort of adapted the World Health Organization aware classification to keep your purposes.
That's right.
Thank you. So the next question here is, what has been the impact of the Orange Network on AMS and prescribing behaviour? I think that might be for you, Professor Taiwo.
Orange Network?
That question came up at the end of your talk.
My presentation.
I'm not
well,
sure.
I'm not familiar. I'm not aware of the support that Orange Network is doing, maybe in Nigeria.
Do any of the panelists have a comment about the Orange Network? And I know that Meryl Davis is listening. She's having trouble with her video camera, so you can't see her face, but she is present and she is listening. If we don't have any comment on the Orange,
they could be doing some things, but I'm not too sure when it comes to antimicrobial stewardship in Nigeria specifically. I'm not familiar with what.
Let's go on to the next question, which is again to you, Professor Taiwo, about in addressing AMR, are there any plans to regulate the sale of antimicrobials, presumably in Nigeria?
Yeah, good question. Yes, this has been a big problem in Nigeria, regulating the antimicrobials. And that's why I felt that in part of my presentation that I think the Nigerian Center for Disease Control, that's the umbrella body that is implementing the National Action Plan. I think there is need to engage the regulatory agencies, the Nigerian Agency for Drug Administration and Control, NAFDAC, and the Pharmacy Council of Nigeria are two regulatory agencies in Nigeria that control the drug supply chain. However, as previously presented, they are hampered by so many infrastructural deficits and personnel. But I also believe that a good engagement of the National Center for Disease, the Nigerian Center for Disease Control with this agency will bring them to the fact that antimicrobials, because they regulate very many drugs, but antimicrobial particularly has not been regulated. But we need to have that regulation because these antimicrobials are present in the populations and they can get it off the shelf without a medical authorization. That's what we've been experiencing in the country, and particularly even in veterinary practice is a big, big issue. So I think there's a need for us to take that action, and LCDC should be able to champion the engagement with these agencies so that we can regulate this.
Thank you. And then also for you, I think from Dr. Iregbu, the National Standard Treatment Guidelines were developed for empiric and definitive treatment of specific infectious diseases with no reference to laboratory support. What do you think will be the impact of this on AMR in communities, medium and long term?
Yeah, excellent question. We've raised these issues in the past. The National Treatment Guidelines are developed without the laboratory components, the susceptibility data from the laboratory. In the first guideline and the one that was the current one, that have been developed, that's not released yet. What we still have is the 2016. We have raised the issue with some of the people that are developing this guideline. If you don't have enough data, you don't have data that's from the laboratory, then what you are producing will be ineffective in the long run. And I hope that before the current new guideline is released, that they will have taken into consideration that, because from what we do in each individual settings, we see a lot of resistance, in our isolates, in vitro resistance in our isolate, and we believe that this is probably what is happening in other centers. So I believe that in reviewing this guideline, they should have data from across all the geopolitical zones, so that you can see the true picture of the in vitro data from the lab that will appropriately guide what should be used as first line or second line. That's what I think.
Great, thank you very much. Excellent. And our next question is, where there are problems with availability of drugs in line with AWARE classification and poor diagnostic capacity, what can be done to address this? Can I pose this to you, Dr. Jayatileki?
Yeah, so a good question again. Because now, as I pointed out in my presentation, diagnostic stewardship is very important because, and also the availability, because now I have seen sometimes, first thing is like, as pointed out by the UK speaker, the rapid test, which may be useful for the doctors to identify whether it's a viral infection or a bacterial infection, which will be very useful. Simple things that we can make them very available in the community, which is not very much used in our country still with the limited resources that we have. But I think those are very important. And then the availability of the access group of antimicrobials whenever they are needed. Sometimes, as I pointed out, we don't have the narrow spectrum antibiotic available, and we have to go for a broader spectrum antibiotic in such situations because we don't have the correct antimicrobial availability. So this is very important that we have to have the drugs available based on whatever the guidelines we have and the stewardship. So I believe that we should have restrictions also for watch and even more than watch, actually, at least for the reserve group of antimicrobials in the community pharmacies, like in our country, because we don't have a very good control over the prescriptions in the community. So otherwise, it's very difficult to control the use of these antimicrobials. So the important thing is, when you don't have proper stewardship in the community, by the time they come to the hospital, they already have third-generation cephalosporin resistance and other important resistance, quinolone resistance, very high levels. So when we talk about a patient who comes to the hospital and when we try to restrict antimicrobials use in the hospital, it's not very, it's not easy, because when you have such a high level of resistance in the community and the patients come with the sepsis, we have to go for carbapenems, which are very important antimicrobials, which we can see the use of our antimicrobial use is like maybe 1,000 times more than what we use in the UK. So this is what we have to have. So that all in all, we have to have a control of the community prescriptions. Otherwise, we'll be having a very big trouble, because it's easy to do something in the hospitals, but it is very difficult to do it in the community. So this is the issue that we are facing.
Yes, definitely. Okay, thank you. Now, our next question goes down a quite different avenue. It's from Dr. Pereira, who's an immunologist, who's asking, is penicillin allergy a problem in your countries, and is delabeling happening? So perhaps both of you would have different perspectives on that. So should we start with Professor Taiwo?
Yeah, well, penicillin allergy has always been in existence, and we have credible alternatives when you have patients that have allergy. But I don't think it has gotten to such high level that you probably have to withdraw penicillin. I don't think so. So, but there are other, when you ask about penicillin allergy from your patients, of course, that's part of what you ask, ordinarily. When a patient has exhibited allergy in the past, you don't want to give penicillin. So you have alternatives to have, macrolides and some other that are that can be used as alternative in such cases. But it hasn't risen to such a level that it will become a national issue.
Yes. In the UK, we have, and I think many other countries, I'm sure, over-reporting of penicillin allergy by patients and attempts to identify those who are truly allergic. What's the situation in Sri Lanka on that?
Yeah, we have the same problem because one thing is that they say, okay, allergic to this so many sometimes list of antibiotics, but exactly they don't know what has happened. Maybe especially the penicillin, they will say, okay, we are allergic to penicillin, but they can't remember the incident. They don't know what happened. Maybe somebody, maybe the mother had told them. So when they were young, something had happened. So very difficult. And then even this test that our doctors are, usually they do a skin test, which is probably not standardized. And then that also makes them believe that they are allergic. So that makes it more difficult because it's just that skin test was positive and that was not a standardized test, which is now like they have got used to just injecting a little bit into the skin and interpreting it. So that makes it even more difficult. So then people are reluctant to give that antibiotic anymore. So this is another issue that we are facing, and there's no facilities for us to get everybody who has this issue because it's so widespread, as you said very correctly. So we don't have facilities to check for this exactly whether it is really an allergy or whether we can desensitize the person. That is a very big issue with us because that makes it sometimes whether to use any beta-lactam or whether at least cephalosporins we may be using, but penicillins we don't like to use when they say that. So that is a major issue.
Do you have any delabeling strategies, or it's just not
it's
really
very limited? It's very limited, only available in the center where the immunologists are, but it's not happening regularly. It's not very there's no strong way of doing it. There's no regular way of doing it. It's very difficult.
Yes, thank you.
Harad, can you hear me?
Yes, we can. Would you like to come in there, Meryl?
Yeah, if that's all right. And sorry for the technical difficulties. For some reason, the camera has decided not to work at all. So within the United Kingdom, we have the same problem from the perspective of a lot of incorrect penicillin allergy labels, and we believe that at least more than 90% are incorrect labels of penicillin allergy. And the British Society for Allergy and Clinical Immunology has actually published a guideline for the evaluation and testing of patients that have an unsubstantiated label of penicillin allergy. The Scottish Antimicrobial Prescribing Group have also developed a guideline for delabeling penicillin allergy. And I know that in Wales, there is a guideline for delabeling patients in secondary care soon to be published. We have the same issue from the perspective of having not enough allergy specialists to try and manage this issue, because we know obviously that patients with a penicillin allergy label, the evidence base tells us that they've got worse morbidity and mortality and a higher risk of antimicrobial resistance and healthcare associated infections. So it is a problem. And with the development of these delabeling guidelines, they're trying to set it up in a way that for those people who are very unlikely to have a penicillin allergy, that delabeling can be done by a non-allergy specialist, if that makes sense. And the hope is that we can have a look to develop something for our primary care clinicians as well, where if somebody has a label of a penicillin allergy on their clinical system, but has had 3 courses of penicillin since that label, then people can probably safely say that they don't have a penicillin allergy. So there is a piece of work being done on this in the United Kingdom at the moment. We know that it's a problem. And during on Penicillin Allergy Awareness Day last year on September the 28th, there was a large campaign done from the perspective on penicillin allergy delabeling in the United Kingdom. And it did have a lot of traction and had a lot of media coverage in the United Kingdom last year.
Thanks very much, Meryl, for that. Thank you. So there are a few comments here about the Orange Network in Nigeria. We'll come back to those in a minute and collect them together. And then we have a question about sale of antibiotics over the counter being the primary challenge for AMI in Nigeria, but I think that we have already talked about that. Professor Taiwo has already answered a question about sales of antibiotics. So I'm coming on to another question now, which is probably for Meryl, about community point of care testing, saying, I'm wondering whether we see an overall consensus for a national drive for such diagnostics to assist with common pathogens. Any feedback on whether more areas in the country are taking up point of care testing, and how can we push this agenda in individual practices without antagonising colleagues?
So I can speak about it from the perspective of Wales. So I obviously mentioned the sore throat test and street service, which is available within community pharmacy in Wales. There's also been recently where we had some point of care testing machines purchased during the COVID pandemic, and they're currently being repurposed in Wales to be shared across the health boards in Wales, and that could be to community pharmacy or it could be to GP practice, looking specifically at CRP point of care testing. And from that perspective, those machines would be funded centrally, and also some of the diagnostics strips and such also being funded centrally to try and negate that antagonism from the perspective of the ongoing cost, but it also ensures quality assurance for those machines as well. Within Wales, we do have a diagnostic work stream from the perspective of our Antimicrobial Stewardship Delivery Board. And it's one of the key areas that when you speak to clinicians, they will always say, it's always difficult when you're not sure. And if we had a test that told us if this is viral or bacterial, that would really help us from the perspective of antimicrobial stewardship and not prescribe when we don't need to be doing so. And there probably needs to be a drive from our innovators and IT individuals as well from the perspective of developing these tests as well, because it's not just about the cost of buying them, it's about developing appropriate tests as well that can be rapid and at the point of prescribing that we need at the moment.
Thanks, Meryl. Great. So I'm coming back to the Orange Network now. We've got a few comments on this. It's an infection prevention and control network in Nigeria. We have a question, are the clinical microbiologists in Nigeria part of this network? And if they are, is there an opportunity here to leverage, to extend to AMR as well as IPC? Professor Taiwo.
Yes, I was talking on antimicrobial stewardship. I know the Orange Network has to do with infection prevention and control. We have other associations, Nigerian Society for Infection Control. And our members are also part of this, that society, and so we work hand in hand, really. But when it comes to antimicrobial stewardship, particularly, I know of the IPC that they do, but not on specific antimicrobial stewardship. But there's room to work together because IPC is a critical help to antimicrobial stewardship. If you have resistance that emerged, if it cannot spread, then it's not going to. It's not going to cause much damage. So IPC is equally very important. And so I think Orange Network would be very a good partner to medicine as well.
And a follow-up question. Do you think it's better to have the AMS subcommittee submit as part of the IPC committee, or better to have them both separately? I'll take everyone's opinion on that, starting with you, Professor Taiwo.
Well, it depends. If the National Action Plan has 5 strategies, and one of the strategy area is antimicrobial stewardship as a standalone. We have IPC, WASH, and biosecurity as also a standalone strategy. Okay, so in your facility, you can be a standalone as antimicrobial stewardship, IPC working hand in hand. But that depends on the personnel that you have. In my own center, for example, we don't have this large number of personnel. So what we have done is to have, because IPC started much earlier. So what we did was to have an AMS as a subcommittee of that IPC. At least that's how we operate. And I know quite a number of centers operate like that. But there are some centers that they have enough personnel. So they have IPC, they have AMS as separate committees, and they work hand in hand to ensure that antimicrobial stewardship activities are carried out and actions are implemented.
Sure. Yes. Thank you. And Dr. Jayataleki, what's your take on that?
Yeah, I think I agree with him because, I mean, it depends on what you have and how the facilities can be used maximally, because now in our Sri Lanka, most of the hospitals have just one clinical microbiologist who is trained on IPC as well as antimicrobial stewardship and so on. So we have to lead both. And then there is a committee, like we have drug and therapeutic committees as well, which we try to link our antimicrobial stewardship with the drug and therapeutic committees in the hospitals. But in the community, again, we have a good public health system where the preventive side, we have more like there are public health inspectors, the midwives working in the community for preventive side. So I think if you can link the two, it would be good. That's why I mentioned in my presentation, we have a good public health system where we use our vaccines, can go to the end user through them. So we have a very good coverage of vaccines, and prevention side is okay with that. Dengue prevention, we are doing a lot of things. So if we link the two together, it would be more efficacious because we have a system in place. So if we can use that system for AMS, it would be good, antimicrobial stewardship. But on the other hand, the pharmacists have to play a major role here in the antimicrobial stewardship. So therefore, we have to link, because the pharmacists are not very much linked to the infection prevention and control teams. So if you link the two, and if they can work together, it will be the best thing for our country, I think.
Thank you very much. Great. And Meryl, have you got a view on combining the AMS and IPC committee, or keeping them separate, or just co-working?
It's very difficult, isn't it? Because IPNC and AMS are distinct in certain nature and have separate pieces of work to be completing, but they're inextricably linked as well. So from my perspective, there's probably separate pieces of work that can be done in certain instances, but there are certain pieces of work that should be done as a co-work. So, for example, there's a UTI working group within Wales, which includes both IPNC and antimicrobial stewardship activities. And because of that, everybody comes together, because there's things around diagnostic, prevention of infection, catheter, etc., that are more towards the IPNC side, but then the management is more towards the antimicrobial stewardship side. So sometimes I think it's better to work separately but be linked together, but sometimes it's better to be co-working on certain pieces of work as well.
Thank you. That seems to be the consensus from the three of you. So thanks very much. I've got a question actually for Dr. Jayataleki, if you would be able to answer this. You've mentioned in your presentation IT, mobile phone use, and female literacy as strengths. Can you elaborate on how you can use these in AMS in the community?
Yeah, because I have noticed, like, when we look at the female literacy, for instance, because the mothers play a major role in our families. So if we can educate the females, we can I mean, the mother will decide whether we need to give antibiotic for this child, or whether we need to take this to the doctor, or we can take it over the pharmacy, because our females are strong, and most of our families are, you know, like we have strong mothers. So, and they are educated, they can be trained, they can be educated. So as a mother, if you can educate the mother when they come to the hospital with the child, to give the necessary education on the antimicrobial resistance and what to do with an infection. So that will be very useful, I think, to implement this in the community. And also the IT, which is a very important tool that we have to use and with the mobile phone use now. Even though we are a low middle income country, we have a very good use of, I think it's like 2 per person, I think we have phones. So people are using phones, and even during the COVID time, we used the online platform for education, like in other countries, and maybe there were pros and cons. There were areas which did not have facilities, but now it improved with the COVID, because people were giving more and more facilities, more internet coverage and all that to different areas. And now we have this system. So that can be used for education and giving guidelines, and even for maybe like apps can be used. And with the bioinformatics, we can gather data, like we can see the consumption data from the pharmacists, because pharmacy data, like, or maybe from the beyond that, we can see the like importers. All these are now computerized. The data is in the computers. So it is just to get the data and analyze. So if you have a regular system, we can, if you have the legal background to this, I think there's a lot of data outside which we can use and analyze and see where we have the problems. So these are my views. Thank you.
Thank you very much. Thank you. We're getting to the end of our allocated time now. I'm going to reshare my slides now to start wrapping up on this webinar. So all of the webinars that we've had will be recorded and stored on our website in the International Regions section underneath the category Virtual Resources, as you can see here. There'll be a section entitled Global Antimicrobial Resistance Webinar Series, where you'll find the recordings hopefully uploaded around 2 weeks after each webinar to allow time for editing. We hope that we'll see you all at our next webinar next week, where we'll be looking at antimicrobial stewardship in secondary care. And the link is there for you to register, or you can find it on the website. Remember as well that the international team will be delivering International Pathology Day on the 6th of November, and the theme this year will be on antimicrobial resistance, so you may well find that interesting. And again, you can register for that on the conference's webpage of our website. We will be sending around a brief feedback form after the webinar, which we would really appreciate your feedback on. It's very short. But most of all, I would like to thank Meryl Davis, Professor Taiwo, and Dr. Jayatuleki for their fantastic contributions to not only to giving their presentations, but also to the Q&A and for answering all those questions so clearly and interestingly. Thank you so much for supporting us, all three of you. Thank you for all your hard work. And I also would like to thank Kelly and Giles in our international team, who've put in so much work to ensure that this series runs smoothly. So a huge thank you to them as well for all their hard work. And lastly, thank you all for attending this webinar. I hope that you found it of interest and useful, and I hope to see you next week at our next webinar. Thanks very much, everyone. Goodbye.
Thank you.
Thank you.
Bye-bye. Thank you so much. Bye.